Well, good night. Your student, Dolphy Gilpin. I'm here in Decatur, Georgia, United States of America. 1524 LaVista Drive on the second floor. And I'm continuing with electrocardiogram. We had done a 20-minute lecture on electrocardiogram the last time. And I'm continuing. And this is from now both an engineering perspective and an engineering medical perspective. Now we see that an oscilloscope, and I must apologize for the view. We should have had more amplified view, more larger view, but this is what we can facilitate at this time. An oscilloscope is the best instrument for analyzing the ECG signal, very low voltage amplitude signal with super accuracy. And here I have a diagram just for a basic oscilloscope, a normal oscilloscope, and the waveform produced, the ECG waveform produced by this normal oscilloscope. And I've called this a leader oscilloscope because I had a leader oscilloscope for myself at one time. I've also had a Textronic oscilloscope. So I've just put the name leader there, but this is just a normal oscilloscope generating the ECG waveform. And this is what it looks like on an oscilloscope. And we see once again that the oscilloscope is the best instrument for analyzing the ECG signal waveform with very low voltage amplitude signal with super accuracy and suitable for medical application. The designers can analyze the full spectrum of the signal using an arbitrary wave generator, we abbreviated AWG. The firmware design of the electrocardiogram equipment can resolve a certain amount of problems that we encounters in generating this ECG to maximum efficiency. And these factors are a few key factors needed to be considered when generating the ECG signals, such as 1, low amplitude signals, plus or minus 1 millivolts to plus or minus 0.5 millivolts. 2, we have a large offset due to RF potential developed at the electrode. 3, we have system noise 50 to 60 hertz from the power lines that form a common mode signal. And 4, complex signal pattern. So those are the 4 key factors, and we are coming here now where we can eliminate them. Now the firmware design of the ECG equipment can resolve the offset developed by the electrode and the common mode signal from the power lines, which was in 2 and 3, by using and the common mode signal from the power lines. And they can use no firmware to remove the power line noise and implement a filter to remove the electrode offset and correct noise. So you see most of these key factors, problems that occur in generating the ECG signals can be removed or reduced to near zero by the firmware designer of the ECG and using the arbitrary wave generators and filters, implement filters to remove the electrode offset and correct noise. Well, up here, what we have here is an ECG going through a simple voltage divider. This is a 10 ohm voltage divider, and you have ECG in and ECG out. You could note the amplitude of these signals and the size, and of the in signal and the out signal, the ECG out signal, this smaller one, proposed to get a plus or minus 1.1 millivolts to 0.5 millivolts, which is what is generated on the ECG paper. Once again, we know that the oscilloscope is the best instrument used to analyze the ECG signal. And this is just a normal oscilloscope showing normal pattern of ECG on a normal oscilloscope. Let's turn over to continue with our well, at the top here, you could see that we have generated a normal ECG, and it's on the ECG paper. It is supposed to, this is a representation of normal ECG paper magnified to a certain scale, because we have the small square is supposed to be 1 millimeter, and one large square is supposed to be 5 millimeters. So here it is, the normal ECG with the P wave, which is said to be the contraction of the atrium, the upper chamber contraction, and this straight PQ segment here, P to right here, is where it said that the signal now enters into the bottom chamber, which are the ventricles, and from there you will get the QRX complex, which is represent the contraction of the ventricles. The QRS represent the contraction of the ventricles. Then we have now the ST segment and the ST interval, and the T wave. The T wave represented the relaxation of the ventricle, and there's a small U wave which is sometimes negligible, sometimes unseen, but there's a U wave, and it is not clear the source of this U wave, what is said to be generated from the Purkinje fibers. On the second waveform of the ECG, we know that we have what you call a ST elevation, moving from a normal note to a ST elevation, called ST-E elevation and MI myocardial infarction. STEMI, representing ST elevation myocardial infarction. And you have the P wave once again, and this segment here is a Q, P, Q, R, S, and T. And we know that the elevation in the ST waveform here, this is the PR interval from here to here, and this is the QT interval from here to here. From here to here would represent the the QRS interval from here to here, which is from here to here. So that's an ST elevation myocardial infarction representation called STEMI. And down at the bottom one here, it's just the same normal representation for normal electrocardiogram. And what we have is the P wave, which we have said before, which is now the contraction of the atriums, the atrium and this from here to here, the ST segment, and then this straight segment here, the ST segment, is where the electrical impulses goes down to the bottom chamber or the ventricles, the ST segment. And from here, we have the QRS complex, which is where you have the contraction of the ventricles. And here, what we have is the T wave here, which is a relaxation of the ventricle, and the U wave, which is generated from the Purkinje fibers, said to be represented from the repolarization of the Purkinje fibers. Next over here, what we have now is some signals, electrocardiogram signal. We have 1, 2, 3, 4, 5 representation of electrocardiogram signal, and we apologize for the minuscule or small size of this signal that is not visible maximally for the observers. But here we have a normal sinus rhythm at the top here, normal sinus rhythm in this representation of ECG. Let's try to restore normal sinus rhythm. And then in the second representation, we have ventricular fibrillation. ventricular fibrillation representation there. And then the third, what we have atrioventricular block. Atrioventricular block. And the fourth, what we have a premature ventricular contraction. Premature ventricular contraction. And the fifth, we have atrial flutter. Atrial flutter representation. And over here, what we have now is a simple diagram of the heart and the signals generated from the various points of the heart. And we have now point 1, here we have the sinus node, and this is the signal generated for the sinus node. And 2, we have the atrial muscles. Atrial muscles, we have the atrium and the atrial muscles, and this is a signal generated by the atrial muscles. The second one here coming down and going like that. And thirdly, what we have is the AV node, the third signal, the AV node coming from here, and this is the signal representation of the AV node. And then fourth, what we have, the common bundle. For the common bundle in the heart, what we have here is the fourth, and it's a fourth signal, this is the one for the common bundle. And the fifth, we have now the bundle branches here for the fifth. And here is the bundle branches in yellow. I don't know if this video can differentiate between the color code used in this representation. For this one was in orange, then this was blue, this was sky blue, this was sort of violet, and then this was yellow. But I don't, the differentiation of colors are seen very vividly. So the fifth, we have the bundle branches here, and this is a signal for the bundle branches. And the sixth, we have the Purkinje fiber, and this is the sixth signal here for the Purkinje fiber. And remember now, the U wave is said to be generated by the repolarization from this Purkinje fiber. The sixth, what we have is the sixth is the Purkinje fiber, and the seventh and eighth is the ventricular muscles. These two signals, these two last one, the ventricular muscles, and this is the ventricular muscles. And this is the diagram of the heart and the corresponding points in the heart and the corresponding signal from the ECG generated at these various points. And here what we have is a representation of normal ECG here again. And I don't know if you could see the elevation here, ST elevation for this one. And we could also draw for ST depression as well. Elevation, ST elevation is just up, amplitude is up in the vertical scale, and the ST depression, it is a depression, it is down. So these are just some more notes on our ECG at this time, and we'll continue as time goes by to use our notes on our electrocardiogram and to have a better understanding of this diagnostic instrumentation, electrocardiogram, used to measure the electrical activity of the heart. And note we could have now what we call a resting ECG, in which the patient lies down and a 12 lead are attached to the body, you know, various points in the chest, hands, and going down, 12 leads, electrocardiogram. And we could also have what we call a stress ECG, and this one is taken by the patient running on a treadmill, and the electrocardiogram leads attached to the patient and the measurement of the ECG obtained. So, but there are two different types, the resting ECG and the stress ECG. So with this, we're going to take a break and rest from our electrocardiogram. And we have also the electroencephalograms and electromyograms, electroretinograms, electrocoolograms that we have not covered, but for the moment. We'll take these things in random fashion. There's no, we're not going to say that the next lecture is going to be on electroencephalograms or electroretinograms, but according to the necessity of the person providing these 20 minutes, 15 minutes lectures on engineering and medical aspect, engineering and medicine aspect of research. Note once again that my first personal record of ECG was at the CCNY, in which a joint course with the Mount Sinai Hospital and the City College of the City University of New York, a joint course led to the theoretical aspect of ECG being taught in a LK technology course with both engineering and a nurse doctor. She had a doctor in nursing, and Dr. Pennington was her name, and there was also a professional engineer who taught the course, and which led to a practical being done at the Mount Sinai Hospital. That was my first professional course back in about 1982, 83. And since then we have done many practical and theoretical research in this ECG, as well as a heuristic approach. I'm not to leave out the heuristic approach which was done. And this also provided insights, practical insights and understanding into this electrocardiogram and its measurement in other hard electrical activities. So we'll take a break here and return once again with some other lectures in engineering medicine.